Okay, so what we're going to be going over are some cases, putting together the concepts that we reviewed about fetal heart rate tracings in addition to labor management. I'm just going to make these up on the fly because they're very common, and then we can go over some topics that come up in addition if there needs to be some more of a content review based upon what you guys want to review. So it's important to kind of review these concepts and put them together because all of what you're asked to know about these things and also what interpret clinically is going to be just that. It's going to be clinical, not just the facts themselves. So let's say you have a 30-year-old G3P2002. Okay. She is at 30 plus 1 weeks gestational age. And she complains of pain. Okay. Now, say this is 150. This is 90. Okay. This is your fetal heart rate tracing. Okay. Her vitals are stable. Afebrile vital signs stable. So, how do you evaluate this patient? What's your first step? You could also chat if you want.
One of the steps are going to be NSP.
Well, so what do we think about this? Because that's you're pretty much saying that you have to assess the fetal well-being. And that's what you see here. So what do we think about this?
Would it be variable accelerations?
Accelerations, how do we describe accelerations? Based upon our lecture prior.
Okay. Greater than 15 beats per minute. 2 cases of that within 30 seconds, I think.
It's you want to think about 15 for 15, but basically it's either accelerations or not. So these are accelerations. There's no variable or any sort of thing. It's just accelerations or not. So yeah, the drawing obviously is not 100% perfect, but we can see that we have accels here. How else do you describe tracings? Well, we're not talking about decels, right? Accelerations just are as they are. So you have accels, it's either they're there or they're not. Okay, so what else? We went through the components.
We can look at marked or moderate and mild variability.
Well, you have variability, right? So your terms are, remind yourself now, they're moderate is what you want, right? And this is supposed to be moderate variability. So moderate variability. There's marked, but there's no mild. That's not a thing. It's minimal. And then absent. Okay. So this is moderate variability. Like I told you, it's all a visual estimate, so I don't need the numbers per se. So this is moderate variability. So moderate variability with accelerations, no decelerations. Overall, this is a pretty good fetal heart rate, right? What about this here? What does this represent? This part on the bottom.
Contractions.
Contractions, yeah. So she has 1, maybe 2. So overall, is this reassuring or not, would you say?
No,
Why not?
because the baby's having accelerations without contractions.
And what's wrong with that?
Its heart shouldn't be going up for no reason.
Well, actually, accelerations are a good thing. You want to see this.
Just kidding.
Remember, we had our conversation about non-stress tests, right? NST. And what do you need for an NST? You need these, right? You need your accelerations. And if you're in labor, you don't necessarily need accelerations to maintain a category 1. But for non-stress testing, you do need accelerations. So fluctuations like that are a good thing. So accels, oh, I deleted my whole thing. Nice. Anyway, this gives us an opportunity to look at our criteria once more. Remember that, so this is our absent, minimal, moderate, marked variability, right? So with moderate variability being ideal. But accelerations are abrupt increases. And you were right to say it's 15 beats per minute for about a 15-second duration. But the important thing that I wanted to highlight is that you have 2 or more fetal heart rate accelerations in a 20-minute period for a non-stress test to be quote unquote reactive. So that's a good thing. So getting back to this. So that's my thing. So what we had was we had a 30-year-old G3 para 2002 at 30 plus 1 weeks gestational age, and she's complaining of pain. Okay. And then you had your fetal heart rate tracing, which more or less looks something like this. We had 1 contraction here. And this we said was 150. So I said, what is this a reassuring fetal heart rate tracing or not? What would you say?
It's reassuring.
It's reassuring from a fetal standpoint, yes. But in my mind, 30 weeks and 1, I don't really want to see contractions, do I? Because what does that equal?
Labor.
Preterm labor, right? Preterm labor, potentially. It's a very different story if she's 39 and 1. 39 and 1, you don't, this is beautiful. No problems at all. Maybe she's in early labor, maybe not. So in this situation, you want to rule out preterm labor, right? And we'll have a whole discussion about that. This is very difficult. Okay, let's try a different one. Now that we had a little warm up. One second. Okay, so let's do it like this. So you have a 41-year-old G5 para 4004. She's at 41 plus 2 weeks gestational age and she presents for induction of labor. Okay. This is our 150 mark. Okay. What do we think? Oh, and I didn't give you mom's pulse. Sorry. What do we think about this?
It's non-variable. Right?
It's what?
No, I was saying the heart rate is not variable. It seems almost linear to me, except maybe the first vertical line over there. I'm not sure if I'm seeing correctly.
Well, we'll start kind of from the top. So first thing is baseline, right? How's the baseline?
The baseline is fine.
What would you say it was?
Fine. For the fetus, the baseline, the heart rate is normal. It's within 110 to 160.
Yeah,
Right?
so it's probably about 150, right? So your baseline is, so you have 150 beats per minute, let's say. Okay. Next. What's the next thing you look for?
Contractions, maybe.
Well, its variability is the next thing you look for, okay? So your variability here is, this is what moderate variability looks like. So you have mod variability, which is good. Yeah, exactly in the chat. I see you there. Good. So now what's the next thing? To assess the fetal heart rate tracing.
Do you check for accelerations or decelerations?
Yep, accelerations and decelerations. Now, we don't have any accels, which is okay. And we don't have any decels, which is actually more of what we want to see. So this is okay. Then 4, you look at contractions. And then, okay, so she has 1 contraction. Great. So overall, this is okay. So she's here for induction of labor. Why?
Yeah, she's almost post-term, right?
Well, what is she? She's almost post-term, but she is what? Remember?
I'm not sure.
Its term is 40 weeks. So term is 40 weeks. That's the mom's due date is 40 weeks. Late term is 41 and 0 and 41 to 6. And then post term 42 weeks. So she is here for induction of late term. Usually a patient who has had 4 prior births, usually you'll say, all right, well, you know, if you don't go into labor on your own, when you're late term, 41 weeks, we'll bring you in for induction of labor. Okay. So based on our previous discussion, what information do you need to proceed now? Say you did a history and she has no significant medical problems and pregnancy has otherwise been uncomplicated. Your fetal heart rate tracing is good. 1 contraction. What other information do you need to know?
You want to check in? Okay, history of previous births, I think. I don't know.
Well, say her, well, okay, the for vaginal delivery is uncomplicated. Her history is uncomplicated.
Do you check the frequency of the contractions next?
Well, the contractions say it's say it's 1 every 10 minutes, 1 in 10.
Do you check for cervical dilation?
You sure do. And what if I told you she is 130 minus 3? So we went over Bishop's score. Is this going to be a high or low Bishop score? Even if
I'm
you
not
don't know the
sure.
number. Think about what the components were. The components were position, consistency, effacement, dilation, and station.
It's probably a low score because of a -3.
Yeah, it's low. You have, and I told you that the Bishop score, the components usually follow suit with each other because they're related. Remember that, say, if this is a sagittal view of the vaginal canal, this is the easiest way to remember it. So then this is your anterior fornix, you have your cervix, and then the posterior fornix here, and then this is the uterus. Expert drawing. Here's your little baby fetus. Okay. Expert drawing. Now, when you're not in labor, the cervix is actually very much tucked up and facing. This is posterior, right? This is anterior. So the cervix is firm and posterior, tucked away. And then as the uterus contracts, the cervix will change its orientation and move anterior and soften until it's basically facing out anteriorly. And then it dilates to 10 centimeters, and this little guy gets evicted. So as such, so your Bishop score is low here. So what does that mean you have to do? If I'm bringing this patient for induction of labor, what type of medicines do I have to give her based upon what we discussed?
Oxytocin or something to.
Even more general than that, not a specific one. What types of medicines? It has a name, remember? Yeah, Cytotec is one of them, but what were those called? What is the process called?
Cervical ripening and softening.
Cervical ripening. That's it. She needs cervical ripening because she has a low Bishop score. Cervical ripening. So what can you start with? What would you start with? Rada wants to start with prostaglandins. Okay, prostaglandins. Would you want something else? Also, say we'll use misoprostol. Okay. Yeah, you could also use a balloon with that. Because you usually want to use the balloon if you can, because I had mentioned that dual agents work better. And that's not, my opinion. That's what the research shows. And anecdotally, you'll see that's what you do on the floor. They'll have a, cook and Cytotec. That's exactly that's a great way to start. What would be a reason why you couldn't start with a prostaglandin? Do you remember? Asthma is not a contraindication to this prostaglandin. You're thinking of something else, and I'll get to that. Yeah, previous cesarean deliveries. You cannot use misoprostol with that. So that's why the obstetric history is important to remember. And that's why when we went over in our labor management slides, is that the focus history is very important. So Celine nailed that one. what I'll do is bring up that picture again to saturate your memory. So remember, your prostaglandins include misoprostol and dinoprostol. And that's your cervical ripening agents. Prostaglandins you can use with your cervical Foley, and then oxytocin low dose, but really if you can use your prostaglandins, you should. That's basically what's standard. In a question, they can't really tell you not to use oxytocin with a balloon or not, but they'll say, hey, she had a previous section, wants a Tolac, and then you can't use it, okay? And then your Cook balloon is this, and there's really no contraindications to that. There's relative contraindication if you have ruptured membranes, but you could still use it. So that's a good little review. So that's an example of how you would start an induction for something very straightforward as a late term induction, which is very common. So say in your course of labor, this is what you encounter. So she has a balloon and Cytotec in. And mom complains of pain. What do we think of this fetal heart rate tracing? First of all, is baby doing well or not?
I think it's reassuring. I think baby's doing well.
So you're saying it's a category 1 tracing?
Yes,
Why is that?
because there is 2 accelerations within I don't know the period, the actual period. I think maybe 20 minutes, like you said.
Yeah, this is. 1 second. Sorry about that. So now remember that for NSTs, you need your accelerations, but to be a category 1 tracing, what do you need? Because she's in labor, right? So now it's a category. Having accelerations is good, but you don't need them. But what you do have is moderate variability and no decelerations. So yeah, it is good. It's reassuring. It's category 1. So what about our contractions?
Well, it depends on the stage of labor the mom is in. I think it's fine.
Well, it doesn't really matter on the stage of labor, she's contracting or not. But really this is, so she's contracting about every minute, okay? If you have if you have greater than 5 contractions in a 10-minute period, what does that equal?
Tachysystole.
Right. So she is having tachysystole here. Is that a problem per se?
If it's longer than 30 minutes, I think.
What you got to remember is that it really only matters if there's fetal distress, which there isn't, right? So what's your plan? Say it's been 4 hours. Well, I guess maybe this isn't clear. So in latent labor, you check latent labor, meaning less than 6 centimeters, you do your exams every 4 hours. And when you have a balloon inside too, you tug it, you tug on it. So say you tug on the balloon and it doesn't budge. So what's your plan? What would you do to manage this patient's labor?
What medications is she?
You gave her Cytotec and a cook balloon.
So now can we add PIT?
Why would you want to add PIT?
Good point. Her contractions are fine.
Right.
We
she's-
just speed
she's-
up the cervical opening dilation.
I'm sorry, say that again.
We want to speed up the cervical dilation.
Well, yeah, that is our goal. But if she's already tachysystole, we're not going to really do any of that. So to give you some perspective, your options really include, you can give Cytotec every 4 hours. So you would give either another Cytotec or you would do nothing because the balloon is still in place, right? So for me, I would just reevaluate in 4 more hours. You get that?
What if nothing happens in 4 more hours?
Well, it's a good question, right? If she's contracting like this, I imagine that things would. But if not, and she's contracting like this, then you would give it more time. Now, nothing happening, meaning that, say, the balloon didn't expel, pretty unlikely if you're still having contractions this frequently. And it's obviously not something that's artificial because she wasn't contracting, you gave medicine, and she's also complaining of pain. So, but really you would keep checking it. Your threshold, I suppose, is what you're asking, say nothing happens. So your cook balloon has a 12-hour span, meaning that you have to remove it in 12 hours. You can replace it with another one, but you have to remove it because it's 12-hour max. So and by the way that your sims go is like this. The only thing is that I don't bail you out. Like, your step 3 exam has sections like this. Well, they'll say, okay, what do you want to do? You could write in your answer, and then it'll tell you what you should have done if you didn't do that before. And then you continue. So this is a good little primer for that. And then for the people watching at home, they can review. But so now so you say, all right, we'll just recheck you in 4 hours. So this happens. So what is this called? When you have that decrease. Good, good. Prolonged deceleration. So you can appreciate, you have moderate variability here, but you have now fetal bradycardia. So what do you want to do? And what's happening?
You want to bring out the baby as soon as possible.
Yep. Well, fetus is distressed, but in this and really anything you do, you have to say, well, why? Right? So why is it happening? Why is baby stressed? Sometimes we don't have a reason, but so automatically, regardless of the reason, what's the first step? This is what we discussed in the other lecture. Resuscitative maneuvers, right? which include maternal repositioning, oxygen to mom, fluid bolus. But given this situation that we have here, what is also something you should probably consider as your etiology?
Could it be umbilical cord compression? I don't know.
Well, umbilical cord compression will look a little different, and I'll show you what that's about. But head compression will give you early decelerations. It won't give you this. I'll give you a hint. You can see it. What are these doing? So I told you that tachysystole is not a problem if baby is doing okay. But here, baby's starting to get stressed out because the contractions are too frequent where the fetus can't recover. Because what's happening is uterus is contracting and that's cutting off the blood supply, at least that's the thought anyway, and that's causing baby to be stressed. You could appreciate that because there's still moderate variability, the fetal status is otherwise reassuring, right? It's like if baby is doing okay, but just can't catch a breath. So what do we do in this situation? What do we administer? Well, this is when we spoke about tocolytics. So you're going to give something called terbutaline. That is a beta-2 agonist. So it's a lot like albuterol. And that will relax the uterus enough. It will quiesce the uterus enough. Usually what ends up happening, you end up getting a pattern that looks a bit more reasonable. And you'll see that this pattern will pick up. But something you will notice is that say this is 150, then fetus will be tachy, but mom will also get tachy too. That's a side effect of terbutaline, but it also helps you because it's like, you know what, I want mom and fetus to be a little tachy considering that there was terminal bradycardia. And then as you can see, it recovers and you have an accel and we're okay. Remind yourself of your resuscitative maneuvers. Okay. So remember, we had said that your resuscitative maneuvers include promoting fetal oxygenation and improving uteroplacental blood flow, but also reducing the uterine activity when you have tachysystole with a category 2 tracing, which is prolonged bradycardia. And you give your tocolytic, which is terbutaline, all right? So it actually works very well. And your other things include initiate a lateral positioning, which means basically turning mom side to side, maternal oxygen, IV fluid bolus, etc. So this is an important thing to review. Moving along in our scenario, if you have questions along the way, feel free to interject. Okay. All right. So say mom recovers. She was in pain, so she requested an epidural and you ordered it. You examine her, and the balloon spontaneously passed, which usually is what happens. And her exam, which is sometimes abbreviated by SVE, which is sterile vaginal exam, is 690 minus 2. She's still intact. Membranes, this is how it's usually written. The tracing is this. What now? What do you do now? What can you do now?
Rupture the membrane.
That's what I would do. Especially because you have a multiparous patient, but either way, you're now in active labor, aren't you? So that's an excellent option. Say she was, the balloon passed and she's 4 centimeters. You could AROM. What else could you do at this point? This is option A, which I think is a good one. There's option B, and there's option C. Because this is how you sort of think. When you're managing labor, you're like, all right, now I have about 3 options.
You just wait for her to dilate further
You could.
without doing anything.
You could expectantly manage because her contractions are about every 2 to 3 minutes. Seeing as how she was just tachysystole, maybe, obviously her uterus is doing things. So you could expectantly manage. Or what?
Give something to help her dilate.
Which includes really only one thing, which is
Are you, would you be able to use a balloon again since you've already used one?
well, once you're done with your cervical ripening phase, which is what happens when you're 4 centimeters and now your Bishop's 4 is good. So you're no longer needing that. So what do you do for augmentation of labor? You could AROM or oxytocin, exactly. This is when you start your oxytocin infusion. Either one of these is acceptable, with your AROM being preferable here because she's 6 centimeters, or even if she was 4 centimeters. As a multiparous patient, that's ideal. And also the way you want to think about it is like, what do I have in my arsenal, right? So that's how, after you're done with your cervical ripening phase, that's the next phase. It's like that. Keep in mind, you're always revisiting your fetal heart rate tracing the whole time. That's why you have continuous fetal monitoring. So it will largely guide your decisions. So you performed your amniotomy, right? Okay. This is what you now see. What do we think is happening here?
That's not good. It's not reassuring.
Well, it's definitely something we need to address.
Is that
Even
a
with,
late deceleration?
well, I wouldn't say it's a late decel. Why do I say that?
Well, because one of the what do you call it? One of the heart rates falls exactly within the same time the contraction happens, right?
Well, it's for two reasons. It is the timing. It is a variable decel. So correct. But it's like this. So this is something you kind of want to get into your head because it's a little difficult. So first of all, like I said before, you always want to know, there's usually a reason why your fetal heart rate tracing is as it is. So why do we think that this patient is having variables? Because first of all, what do variables mean? Yeah, cord compression. And we just ruptured this patient's membranes, right? So it stands to reason that the cord probably is being compressed. So that's like your, no, that's your like highest on your differential as a reason why. But also, look at the way I drew the shape. Remember I told you early and late decels tend to be smooth. The reason why is that once the cord is compressed, the blood flow is pinched off. So that then causes an increase in the heart rate of the fetus, which you see this kind of slope, because it's trying to pump more to get the blood, but because then it realizes it's not getting it, the heart rate goes way down. And once the compression stops, it goes back up. So it has this sort of like V shape. That's how an easy way to remember it. Variables have like this V shape, okay? And they're not related to the contractions. I mean, I know that it kind of looks like it is here, but this one is at the end. If you actually look, this one is kind of like on top of it. So it's not related. And this one's almost directly on top of it. So they're not synchronous. A late decel would look like this. Say it's like that. You would have right? You see how it starts just as the contraction ends. And that is indicative of uteroplacental insufficiency. Yeah, exactly. It says when you have the, when it's compressed, you have an increase in the peripheral resistance, and then you get this reflex bradycardia, like to compensate it as well. It's like both of those things are happening. Because I mean, it's just like, that's just cardiac physiology. It's like, it's the same thing as I kind of said. It's just that you have your total peripheral resistance jumps up because all of a sudden you have to try to push against something that's pinched off, right? And then the bradycardia is compensating for that because it originally tries to respond by saying, maybe I can overcome this, but clearly it can't because it's pinched off. So then it sort of gives up and then it goes down, right? Because then if you remember your cardiac physiology, it's like, the baby can increase their blood volume if the heart starts to pump faster. But if it's not working, to get that volume back, the heart has to relax and fill. That's also another way to think of it. Regardless of how you remember it, it's all kind of saying the same thing. But that's helpful to remember because it actually relates to what's actually happening, like in just any sort of cardiac situation. And are there nuances of that that are better explained by a cardiologist? I am 100% sure that is not me. So, oh, and let's mention early decelerations are what? While we're on the subject, head compression, very good. And that looks like pretty much like late decels, but they're actually right on top of the contractions, okay? And those are, that's a good thing. Well, it's not a good or a bad thing, I should say. You still maintain category 1 status, but that's only because if you put pressure on the fetal head, that's making the fetus think, oh, well, I have increased intracranial pressure, which means I'm going to lower my heart rate. Right, exactly. It's that reflex. It's because you have an increase in intracranial pressure. Because if the body thinks that, it's going to lower its heart rate because it doesn't want to be pushing up against that. It's just pushing up against that pressure. It's the same thing with the oculocephalic reflex. You know, if you push on your eyes and stuff like that, your heart rate is going to go down. That's why people even instinctually do that without thinking about it. So those are the main ones you need to remember. And this is key in labor management because you know what to do. So it all relates. And it's important to review it for yourself because to put it together in a way that actually makes sense. So to remind you, pull up the chart that I had showed you in the other lecture. And we'll just briefly go through it. I did draw it, but you know, my drawing is not great. So uteroplacental insufficiency, you see the late onset and late recovery of the deceleration, okay? A variable, like I said, it has this notched sort of appearance. And that's because it's due to the umbilical cord compression, prolonged decel. And then your early is that it's timed on the onset of the contraction together. It's because of compression of the fetal head. So in our scenario, our patient has prolonged, I mean, she's having recurrent variable decelerations, which, so what do we do about that? So that's technically a category 2 tracing, right? Yep, we could do resuscitative maneuvers and that might resolve it. But what's another thing we can do?
Emergency C-section.
Well, what did I say emergency C-sections are reserved for? Yeah, you're going to amnio-infuse her, right? Amnio-infusion, which is a fancy way of saying we're going to just put some fluid back. In a practical speaking, you use your intrauterine pressure catheter, which I have on the slides in the prior lecture. You give a bolus, usually it's about 600 ml, and then you have a maintenance of about 180 ml. You don't need to know that, but just so you know what's actually happening. And that just gives enough fluid to relieve the compression of the cord. And actually it works very well. So doing this will reduce your need for a stat section. Now, category 2 tracings don't require emergent delivery, but a persistent category 2 tracing is an indication for a cesarean delivery. It's your category 3 tracings, which are your true emergencies requiring delivery. And do we remember what the criteria for that are besides sign disorder pattern, which you don't see very often? It's a very strict criteria. So you need absent variability and so remember, it's absent variability and, okay? Not just absent variability. If you have a fetus and it's like a straight line, and that's actually what it looks like. It's not that it's a completely straight line. It'll have maybe a little twist, but it's straight, right? So if you see this, you're like, oh, yeah, you need that with recurrent lates or recurrent variables, okay? So if say she had, this patient is continuing to have these variable decelerations, right? And then the variability becomes absent. Yeah, well then you're in a category 3 situation. And then you have to proceed with cesarean delivery. Make sense?
Yeah, I got it. Thank you.
Yeah, it's very much, doing this is very standard. But because you all managed this patient so well, she had a successful vaginal delivery. So nice work. But don't be too reassured, because when we're talking about the postpartum hemorrhage lecture and things, then your patient is going to hemorrhage, and I hope you manage that properly. For your simulations, are going to be very much, you walk into a room and I'm going to say, all right, very similar. I'm going to give you your fetal heart rate tracing, which we'll actually have on a monitor that looks real. I'm not just going to draw it. And then you'll have a mannequin there, but there's a bunch of things that she can simulate to do. And then we're going to see what your management is. Our next lecture is going to be on obstetric hemorrhage. So that will encompass postpartum hemorrhage, which is also then once the fetus delivers and you're in your 3rd stage of labor, you have to know how to manage that as well. And then when you learn about hypertensive disorders of pregnancy, well, then you know your patient will be hypertensive, and then you also have to manage her labor, and then she's going to bleed, and then what do you do then? So that is pretty much what makes labor management complicated, because when everything lumps up, okay? Remember, your 1st stage of labor is 0 to 10 centimeters dilated. 2nd stage is when there's complete dilation and you're ready to push. And then 3rd stage is when you deliver the placenta, and this is where you get your postpartum hemorrhages. All right, I think that's good, because that is a very simple example, but very much a synthesis of the first 2 lectures. If you could understand that and how those decisions were made and where the criteria fits in and how to read these things, you're very much on track. So any questions about this, or, you know, you're always welcome to ask questions about anything that you're encountering, OB/GYN, surgery, whatever you're encountering. It doesn't have to be about this topic per se. This is your opportunity to ask and get some clarification on that. If I could send it out. If the PowerPoint slides were not available for the last one, I'll send it out, and I'll also send it with that. I'll send the next slide deck so you could start to review it, because it's kind of long. So with the scholarly activity part of your rotation, I will be sending that out, if not tonight, then tomorrow. And essentially what you can begin to work on, if that's the block you're on, is to pick a topic in OBGYN that you want to learn more about. And really not just in general, probably something that's, you would actually need to look at the published literature to find out. My goal of this is to do a couple of things. One is to get you started on how you would begin to even think about a research project, because I get that every block from students. So I figured I might as well work it into the actual curriculum for you guys. And no matter what you guys end up going into, that's going to be a requirement for you to accomplish. And sometimes your direction in that regard is very poor. So that's the goal. And what I'm going to have you do is pick a topic that you're interested in. And then I'm going to have you I'm going to teach you how to effectively and without much difficulty conduct a literature review to see what that topic, what has been done and what may need to be done in it, and something you could look into. There'll be a module on biostatistics, just with things like sensitivity, specificity, all that stuff that they always test you on, but no one really kind of knows. And then at the end of that week, you'll have a better understanding about that beginning process. Additionally, if there are people who want to be involved with research projects too, that's a good time to coordinate with me about what you can do and be involved with. Our department has performed research and gotten abstracts and now even an oral presentation this year, accepted at the Society of Maternal Fetal Medicine's conference for about 2-3 years. So we've been very successful and we know what to do. So that's the entire point of that block. And I'll be sending that out. It's new, so I don't have it completely minted. That's why I haven't sent it out yet, but it'll be done by the time those students start. So right now, think of a topic. Okay, great. And do me a favor. If your preference is to just do these things virtually, I'm okay with that. I usually like in-person visits, but with COVID waxing and waning, people are kind of discouraging me from doing that with you guys. So if that's your preference, you can email me that and that's what I will do. But I will not deprive those who like the in-person lectures as well. I have things scheduled as they are, but if that's a desire, you guys can let me know. And if there aren't any other questions, then happy studying, and you could always email me with what you need.
Okay, thank you, Dr. Maximiano.
Thank you. Appreciate your participation.